everybody. I'm Anna Morad. I'm the Newborn Nursery Director for Vanderbilt University Medical Center, and here today to talk to you about care of the newborn with opioid exposure. This will be a brief update from our previous TIPQC trainings. So we're going to talk today about a few key ideas. We're going to talk about better care practices. We're going to talk about breastfeeding with the Academy of Breastfeeding Medicine update. We're going to talk about early relational or infant mental health. And these will be things that we'll go through and give you updates on new changes and review some old practices as well. So first we're going to talk about what the definitions are for mom. So the first thing that we need to level set is opioid use disorder, which is a pattern of opioid use leading to clinically significant distress or impairment. And that's important because there can be opioid use that doesn't rise to the level of OUD. The second definition we'll talk about is medication for opioid use disorder, or MOUD. Most people have started moving away from MAT, or medically assisted therapy, and moving over to MOUD as the preferred term. Definitions for the infant. This proposed definition is from the Department of Health and Human Services. It's from a consensus group that I was fortunate enough to be part of, and it was a really interesting process where they took stakeholders from around the country and talked about what we saw clinically and what was most important to make the definition or the clinical diagnosis of NAS or NOWS. And we all agreed that exposure to opioids during pregnancy was probably one of the most important things. You have to have either from maternal report or by toxicology testing evidence of opioid exposure during the pregnancy. And then the most common clinical symptoms, if you have at least two of those, excessive crying, fragmented sleep, tremor, hypertonia, or GI dysfunction, and I interpret that loosely as excessive weight loss or poor feeding. Two of those will meet criteria for NAS or NOWS. So what exactly is the difference between NAS and NOWS? I think it probably would vary a little bit depending on who you ask. I tend to think about NOWS as being more opioid specific, whereas NAS tends to be more of a catch-all. I'm going to use those terms quite interchangeably during this presentation, even though most of our focus will be on opioid exposure. I have found that clinically, a lot of these babies have multiple exposures and aren't simply opioid exposed. So let's talk a little bit about the NOWS timeline, and this is for withdrawal that you would see with babies. This is not a new problem. This actually has been reported as early as the late 1800s, back during the opium den phase, where they did have reports of infants having withdrawal. And then in the 50s and 60s, there was heroin and heroin withdrawals, and then that morphed over into the 70s, where the term neonatal abstinence syndrome, or NAS, was actually coined and made an official diagnosis. That's when the Finnegan scoring system was developed as well. So it's been around for a long time. We'll talk about it a little bit later in the presentation. The late 1980s, early 1990s is when a lot of the opioid prescribing practices were sort of out of control, and we had sort of those pill mills and inappropriate prescribing, which led to a lot of opioid use disorder and in turn increase in diagnosis of NAS. So the American Academy of Pediatrics came up with a protocol in 2012 to address the care for infants who were going through withdrawal, and that was also the same year that the NAS epidemic was declared. Fast forward to about 2016, most states have put into effect strong regulations about opioid prescribing practices and have been able to decrease the amount of street-ready opioids that were available, which in turn led people to look for other alternative substances, and heroin came back in, but rapidly proved to be very expensive, and so then fentanyl took its place, and we are now seeing fentanyl as the majority of our opioid exposure. And synthetic fentanyl is sort of constantly being reconfigured, so it can be difficult to detect. The most important current change has been Eat, Sleep, Console, and that is an assessment protocol that is exactly what it sounds like, to look for infants with withdrawal and to monitor them more carefully, and it's rapidly taking the place of the Finnegan scoring system. So what's next? What do we need to look for on the horizon? I think xylazine will be one of the things that's going to be rapidly becoming a problem. It showed up in our supply around 2020, and it's an animal tranquilizer. It's not an opioid. It is not a controlled substance because it's a veterinary medication. It can't be reversed by naloxone, which makes it incredibly problematic. From peer reports in the eastern part of the state, they are already starting to see quite a bit of xylazine, and TBI has reported quite a bit of xylazine in the drug supply. It's used to extend the effect of fentanyl and also used as somewhat of a filler. Anecdotally, the infants tend to have a more severe withdrawal. So I do think this is something that we'll learn more about as we have the ability to test for it. So what are the patterns in Tennessee? As I alluded to before, the fentanyl rates have increased dramatically. And so you can see from this data set, this is from the Unintentional Drug Overdose Reporting System. This does not include the newer drugs like xylazine, but it looks for what where individuals were found to have overdosed on. And you can see from 2019 to 2022, the rates of fentanyl really skyrocketed, and that tends to be the majority of what we're seeing right now. There's quite a bit of data lag, and so 2022 is the most recent year that we're able to report out. Same with NAS trends, and so this is the NAS trends for Tennessee Department of Health. It has been a reportable disease in Tennessee since 2013. This data does not include the number of infants who are opioid exposed but do not meet the clinical definition for NAS or NOWS. So what do we learn from that? 2022 rate of NAS in Tennessee is 9.8 per 1,000 live births, whereas the national rate is 6.3 per 1,000 live births. So we're still far outpacing the national rate. And then most concerning is 53% in the reported Tennessee cohort did not have adequate prenatal care. So if we don't have the opportunity to get them into prenatal care, then we don't have the opportunity to get them into recovery services. And that just causes long-term effects for baby as well. This is not going to be a surprise to any of you who practice in Tennessee. Our rates of NAS are highest in the eastern part of the state and decrease as you make your way across the state. And so you can see our rates in Sullivan County in the top northeastern part of the state can range 30 to 50 per 1,000 live births. So that's a very high rate of opioid exposure, or NAS. So why do we care? The reason we care is that you can have significant complications from opioid use during pregnancy. The complications for the mom can lead to a very problematic pregnancy. It can lead to overdose. It can even lead to death. And so it's really important for the maternal side to have some recovery efforts put into place. For babies, intrauterine growth restriction, these babies tend to be very small. They have a higher rate of stillbirth. They can have a sudden unexplained neonatal deaths, and so we do see more SIDS in this patient population. And then the particularly huge concern is the neurocognitive delays that we know that these babies may be facing. The causes of infant withdrawal can be quite variable depending on the substance exposed. And so I think it is really important that you recognize that the baby may be opioid exposed, but also may have other exposures. So for instance, we know that opioids can cause NOWS, but we also know that if mom is taking benzodiazepines, that can increase the chances of the baby having withdrawal. There can be antidepressants or tobacco. Those will often cause some mild withdrawal symptoms in the first couple of days, and that can start fairly soon after birth. For your SSRIs, the term would be a neonatal adaptation syndrome, where you can have just a little bit of jitteriness and maybe a little bit of fussiness that can be attributed back to the antidepressant. Alcohol withdrawal, I definitely think that we miss alcohol exposure because there's not a well-described withdrawal syndrome at the time of birth. We know that infants with fetal alcohol syndrome or fetal alcohol spectrum get missed when they're first born. We often miss those clinical signs and symptoms. So we really depend on maternal report to recognize alcohol exposure for these babies. For xylazine, we don't have enough evidence to know what the withdrawal syndrome will be for those infants. So the timing of withdrawal symptoms is also important to recognize. There are some things that you would expect that an infant would have withdrawal fairly soon after birth, such as tobacco or your SSRIs or some of the short-acting opioids can even be a little bit faster. Heroin, fentanyl tend to be a little bit faster. But you wouldn't expect a baby whose mom is on MOUD with methadone or Subutex Suboxone to have really fast withdrawal. You would expect that to be several days into the hospitalization. And so if you do have a baby with withdrawal sooner than you would expect, it's important to go back and ask mom if there are any other medications that she has taken. So the symptoms of NAS or NOWS, and I really like to think about these big buckets of symptoms. I think it's easier than being overwhelmed with lots of little details, but overstimulation. So if you think about that big bucket, that includes irritability, it includes GI disturbance, it includes vomiting and diarrhea, poor feeding, all of those things that we see when the babies get overstimulated and they have difficulty calming. The next one would be altered tone. We know that these babies tend to be jittery. They tend to have a little bit of increased tone and tremor, and those are things that you definitely will see under that category. And then autonomic dysfunction. So that captures your yawning and your sneezing, things that may not be terrifically clinically important, but can be benchmarks of withdrawal. And then sleep. Sleep disturbance tends to be one that we see quite a bit, where there's just poor regulation of the sleep-wake cycle and the babies tend to not rest very well. So let's talk about some better care practices for this patient population. We would be remiss to not talk about trauma-informed approaches in caring for your patient population, especially in this patient population. It can be very important. A lot of our moms have significant trauma, and you need to be cognizant of that when you're caring for them. So this is the SAMHSA guidelines, and let's tackle these very quickly one by one. So safety is your first bullet point. Moms need to feel safe in the environment to be able to give you an accurate history and to be able to best care for their infant. Transparency and trustworthiness. You're not going to earn a mom's trust if you're not being truthful with her about next steps or what you may need to do. So if you need to make a DCS referral, for example, you need to be upfront about that and talk to her about that so that you will be trustworthy and transparent with the next steps that need to happen. Peer support. In our Firefly Clinic, we have peer recovery specialists who have been invaluable in helping support moms. And so if you do have the opportunity to involve AA, Al-Anon, peer support recovery specialist, anybody with a lived experience of recovery who can help support these moms, it's super important and very helpful for them. Collaboration and mutuality. I can't tell you the number of times where you go in and you talk to a mom about her next steps or her recovery plan, and her recovery plan is going to be individualized to her expectations, and it's really important that you respect where she is in her recovery and also recognize what may be the safest option for the baby, but having that collaborative discussion with her about what the next steps could be or what they could look like. Empowerment. So this is really recognizing that individual strengths are always going to be there, and so mom is going to have her own strengths that are important for you to help tease out, and what are her protective qualities that are going to make this a safe discharge for her and the baby. It's also really important to consider the power differences that exist between the medical staff and the family. So some quick tips on that. When you go into the room, sit down, have a conversation, introduce yourself. Don't be afraid to use your first name. Make sure that you are listening first to mom's story and her recovery and what her goals are for this parenting that she's about to embark on, and then have conversations about her next steps, but really recognizing that it has to be a collaborative effort. So the next thing to do is avoid re-traumatizing with your language. So it's incredibly important to use language that respects the family, respects the mom, respects the baby. Parents, I have it happen a lot where they will use disrespectful language towards themselves. And you really want to reframe that. So you don't want to say a dirty urine. You don't want to say a baby that's addicted. Those are outdated and inappropriate terms. You really want to use person-first language. Mom has opioid use disorder. Baby has withdrawal. Those are going to be things that you need to kind of reframe as you're talking to the family. This is a great handout that you can use that you can Google, and it's just Language Matters, and it gives you lots of very specific details about what to say and not say. Hospital care. So let's talk very quickly about some better practices in hospital care, and some of this will be a review, and hopefully you'll pick up some little nuggets that you can take back to implement in your own hospital. So when to consider drug testing for babies, and this is an incredibly important question. You need to have a policy, a consistent screening policy in place but that does not mean universal screening. Universal testing is not recommended by any professional organization. So if you are doing universal drug testing on mom or universal drug testing on baby, it is not recommended. You really need to drill back into that and think about the long-term implications of that. If you pick up a false positive, or if you pick up something that's not clinically impactful, or if you pick up fentanyl in the baby's core drug screen because mom was given fentanyl at the time that she came in to deliver. So it's super important that you have a consistent practice that is evidence-based about when you are going to send testing. It is recommended that all mothers receive validated screening. So when do you test the baby? When it can change the clinical care for the baby. So that is the long and short of it. If you're not going to be making clinical changes, if it's not going to change what you're doing, then there's really no reason to send infant drug testing. So if mom has been compliant with her MOUD, if she's in a recovery system, you've got drug screens that on mom that show that she has been adherent to her recovery, then my question for you would be, why do you need additional testing for baby? It is not going to add any information. It's most likely going to come back after the baby has been discharged, and it's just really not recommended. If mom has had scant prenatal care or no prenatal care and has a positive screen, that would be an instance where an infant drug test could be useful to help further elucidate what the baby may have been exposed to for long-term planning purposes, or if the baby starts to have signs of withdrawal. Always, always discuss it with the family. They need to know that a drug test was sent, and they need to know why. Interestingly, many places are getting away from screening for marijuana or THC, and the reason for that is it's really not shown to have an increase in child maltreatment or abuse. So it's screening for it when there's a fairly large number of patients in our population who are using it and then not really doing anything about it. It's really a waste of time. There are 3 basic ways that infants are tested: urine drug test, cord sample. This is not cord blood, it's actually a physical sample of the cord, and meconium. So recognize that not all of these tests have the same detection window. They don't have an overlap of what they're going to detect. Urine drug screens should really be used in very specific situations. We tend to use them only if mom is altered in triage and we want kind of a rapid answer for what the exposure may be. Cord drug testing is a send out for us. It usually takes 3 to 5 days to return. It does not automatically include THC, and we do not order that as a separate test. Meconium samples can be a little bit trickier. So you need to collect from the first meconium until the stool transitions and then combine the samples to have the most accurate result. It also looks further back into pregnancy than the cord or the urine sample do. Really important to ask yourself though, is that information important? If mom is no longer using those substances that particular sample detects, is it important clinically for the baby or for discharge planning purposes to have a meconium sample? The other thing to be aware of is certain drugs are not going to show up because they're not even tested. So if you have a rapid ED, urine, easy cup, or one of those tests, fentanyl is often not even included in that testing. So it's really important that you know what your hospital includes. Fentanyl in-house testing also has a slightly higher risk for false positives. So you would also want to make sure that you have a higher pre-test probability before you send that test. And then always, always, always wait for the confirmation on any of these tests. Cord comes back with a confirmation, meconium comes back with a confirmation. If you're sending urine, you have to wait for the confirmation before you act on it. You are going to have false positive amphetamine tests all day long, and you really want to make sure that you're not reporting based on that. So the observation protocol, and this is really set out by the American Academy of Pediatrics, and this is a best practice and really important that this is followed. So 3 to 5 days for short-acting opioids, 4 to 7 days for long-acting, with that 4-day being more for the buprenorphine, the 5 to 7 more for the methadone. It will be interesting. There was a recent study published by Dr. Stephen Patrick looking at a risk prediction model, and hopefully one day we'll be able to enter data in a risk prediction tool and potentially change these observation protocols. But at current state, this is what's recommended. Pharmacologic treatment is going to be necessary if the withdrawal symptoms are such that the baby can't maintain their weight or has significant enough symptoms that it's interfering with their ability to be a baby. So non-pharmacologic care is the most important thing that you're going to do for an opioid-exposed baby. We say over and over, mom is medicine. We say to the parents, you're the medicine. We also say things like, you're going to know your baby better than anybody because you're going to be rooming in with your baby. You're going to let us know if he or she seems more fussy. Really giving them that opportunity to be an active participant in the care of their infant, and that's going to be really important. They're the primary source of comfort for them. The non-pharmacologic things that you're going to do, that quiet environment, low light, swings, rockers, swaddles, those kinds of things. Talk about that from the time that they're admitted. It's far easier to talk about a quiet setting and a low TV than to have to go in and turn the lights down and turn the TV down when you haven't gone over it. So setting those expectations really ahead of time. Going to be really important that if you are using a swing or a rocker or a mamaroo or any of those kind of devices, that you've had that safe sleep talk. We have not traditionally had those in the room with the families just because the risk of them falling asleep is so high. So we provide some respite care in our nursery setting if we're going to be using one of those devices. So this is the Finnegan scoring tool, and I bring this up only because I want to remind everybody the number of things that the nursing staff have to look at when they're doing the scoring. And so what we have found sort of over and over is our inter-rater reliability is not great. There are plenty of times where an infant has scores in the 20s and you come in the morning to do rounds and the baby's sleeping comfortably and they had a bad night, and depending on the timing of which they were scored and how they were scored, it is very easy to get a score that is just not appropriate for what you're actually seeing. So I would highly encourage you, if you are using Finnegan scoring, to make a few modifications that potentially could help to increase your inter-rater reliability. First thing is huddling as a care team. So making sure that if you are getting a higher score, that you're bringing another nurse in to double score with you, that you're involving the family in that scoring and talking about ways that maybe you could reduce the score. If you're scoring in a nursery setting, I can't tell you enough how important it is to get the baby back out with the mom or with the caregiver in a quiet environment and then redo the scoring. Don't wake a sleeping baby. By definition, if they're sleeping, they're not withdrawing to the point where they need immediate morphine or immediate pharmacologic treatment. So let them sleep. Make a plan with the family or with the caregiver that you will come back when it's time to feed the baby, and then do your assessment at that point in time. So excoriations should be new or worsening to be scored. Babies will often have a scratch on their cheek because they like to keep their hands up near their face. That does not necessarily need to be scored as a withdrawal symptoms. Really what that is meaning is that severe chafing that you'll see on the chin when the babies are really frantic and having a lot of irritability. That is when excoriation should be scored. Those minor excoriations that have been there since the baby was born, you want to be careful not to score those. Breastfeeding stools are not diarrhea, so look for a water ring or a large volume watery stool before you score that. The other thing is being careful not to double score items. So if you have an undisturbed tremor where the baby is already jumpy, obviously when you disturb them, they're still going to have a tremor. So you want to be careful not to rack up points by inappropriate scoring. So Eat, Sleep, Console started in 2019. It started at Yale with Dr. Matt Grossman and has rapidly spread to be the most common assessment tool used in the scoring of NAS or NOWS. And it is exactly what it sounds like. It is, can the baby eat? Can they coordinate their feeds with a good latch? Can they take at least 10 mLs or feed at least 10 minutes on the breast, or whatever is age appropriate for the age that they are? Can they sleep at least an hour? And can they console within 10 minutes? This makes total sense to families. They can wrap their heads around it. They understand what they need to be looking for. If the baby fails to meet one of these domains, let's say they just aren't feeding well, they've got excessive weight loss, and they just aren't doing well, then you huddle. You huddle with the family first. So you go and you talk to the family and you say, hey, let's go over what we can be doing here with our non-pharmacologic therapies. And you go point by point. Do we need to increase the rooming in? Do we need to supplement? Do we need to add a sound machine? And you can sort of walk your way through those things and make sure that you're optimizing everything that you can do to decrease the withdrawal symptoms for the baby. If you've gone through these things and the baby is still failing the eat, sleep, console domains, that point you call the provider and you huddle with the provider and the family. So this should all be a collaborative effort that you're making these decisions as a team. I will say most families will tell you it's time. It's time. I think my baby needs to be treated because they've done everything that they can to minimize these withdrawal symptoms, and it's apparent to everybody that it's time to do something differently. Once you have started morphine or whatever your hospital uses for withdrawal, you're still going to use Eat, Sleep, Console. At that point, the baby should be able to function and to have those domains met. And if they don't, let's say you give a dose of morphine and they're still not sleeping or they're still not eating well, then it's time to consider scheduled morphine or maybe some clonidine or whatever your hospital algorithm is for next steps. So let's quickly compare our Eat, Sleep, Console model and our Finnegan scoring model. And really, when you're thinking about Eat, Sleep, Console, it's a functional model. How well is the baby babying? You want to make sure that that baby can eat, sleep, and console, exactly what it sounds like. Finnegan scoring looks for multiple symptoms that the baby has that may or may not be important to let you know how severe their withdrawal is. I can tell you our change to Eat, Sleep, Console is probably one of the most popular changes we've made, both from a family reception of it and nursing. It decreases your nursing time with documentation. It decreases the confusion about what to score and not score. And it's just a far simpler way to go about assessing a baby. The scoring for the Eat, Sleep, Console is a yes-no decision tree. The shorter length of stay has been shown with the Eat, Sleep, Console model. And then again, it emphasizes parental involvement, which is absolutely critical for these babies. So our next key idea is breastfeeding. This is really important to do a deeper dive into that will be far longer than the scope of this talk, but I would encourage you all to go and find the Academy of Breastfeeding Medicine Clinical Protocol number 21. It's readily available on their website. It is incredibly well done, well thought out, and very, very detailed. And so our previous ABM protocols had sort of a 30-day, 90-day cutoff about when to breastfeed, when to not breastfeed. And what they found when they looked at the literature and looked at what was most predictive of ongoing use, it was really what was mom using at the time that she came in to deliver? What was that triage drug screen positive for? And that had more predictive value than any relapses in that third trimester. And so what they've encouraged is that if a mom is on MOUD with buprenorphine or methadone, if she's discontinued non-prescribed substances or non-prescribed medications by the time of delivery, then you address it with a team-based trauma-informed approach. You make a decision with mom about her ability to breastfeed or not breastfeed. You've got time to do this. And this is one thing that I can't emphasize enough. Like, this does not have to be made lickety-split at delivery. You may have already made this in conjunction with your OB colleagues if you've been following mom in recovery and you know that she's not in a stable place. But you can also have this discussion when mom comes in to deliver, because the volume of colostrum is going to be incredibly low when that baby's first born. You've got time to make a team-based approach decision. You can't really test breast milk. There's not reliable data with testing breast milk for drugs or substances, and there's not really great cutoffs, and most labs are not going to accept that. So the ABM does a great job of laying out what the timing is of the peak effect of these substances, the half-life of the substances, and what the relative infant dose would be. So you can use this chart to determine whether it would be reasonable to allow or encourage breastfeeding. If there is a discontinuation plan, then you also would want to talk to your OB colleagues, because there are situations where you would encourage mom to pump and dump and not give the breast milk in the hospital setting, but work on a discontinuation plan with her OB and continue that process as an outpatient. So what about non-prescribed medications or illicit substances? So breastfeeding is not going to be recommended if there's ongoing use of non-prescribed opioids, stimulants, or sedatives. If mom is not in a recovery place and is actively using at the time that she comes in to deliver, then breastfeeding is going to be contraindicated.
Not advised again with benzo use or misuse, but it could potentially be allowable if mom is on a benzo taper or if she's on PRN benzos that are being well monitored. If there are questions about that, going to the Infant Risk Center and calling with that benzo dose can be really useful to know whether it's reasonable to allow. Alcohol is likely safe with occasional and modest use. Modest is the term that the ABM uses in the protocol, and they have clarified that to mean 2 glasses of 150 milliliters of wine or 1.5 pints of beer during lactation with a 2-hour waiting period after. Tobacco and vaping we obviously encourage our moms to stop those things, but they are not a contraindication to breastfeeding. And so we do want them to use reasonable precautions, such as covering their hair, using a smoking jacket, those types of things. They need to be aware that it does get into the breast milk. If they are vaping marijuana or THC, then that does accumulate in the breast milk. For breastfeeding and fentanyl, we have already talked about the amount of fentanyl that's in the drug supply these days. The ABM protocol says approximately 90% of illicit opioids are contaminated or mostly fentanyl. Drug accumulation of fentanyl is a huge concern. So the one thing to be aware of is it does deposit into fat stores for the mom. So she may continue to test positive for fentanyl for months and months after she has discontinued use. We have seen it in our clinic for a year plus that mom would continue to test positive. We are able to quantify the fentanyl level, and so you can see the difference between active use and when she has discontinued use, and that quantitative number is incredibly low, but will bounce around a little bit because it's just in her fat stores. So again, a point of drug testing is not always straightforward, and it's important if you have an addiction medicine specialist or an OBGYN to consult with them or your lab colleagues before you make decisions about whether this baby has had fentanyl exposure. Breastfeeding and stimulants, can be incredibly dangerous. This isn't something that we would allow breastfeeding on. So if mom is actively using cocaine, methamphetamine, or amphetamine, that is a very high risk situation. Those particular medications have a low molecular weight, they are soluble in lipids, high bioavailability, and so they are going to get into the milk supply readily. The mom can also experience fairly low milk volume because she produces less prolactin. And then some of these, even prescribed amphetamine, can accumulate. And so you really want to be careful that you're watching the infant's weight, that you're watching for irritability and those kinds of things. If there's any questions, again, I would check LactMed or the Infant Risk Center to determine if it's safe for mom to breastfeed. There are concerns with infant death, and there have been 3 documented cases reported in the literature, at least, for infant death after methamphetamine exposure with breastfeeding. So that is something that we really and truly would not recommend. It would be truly contraindicated to breastfeed. And then let's talk about marijuana. So the National Survey of Drug Use and Health from 2021 reported that 7.2% of pregnant women have used cannabis or THC in the past month. And this is a fairly large number. It was a little bit surprising to me, but the ABM points out that the dispensaries where marijuana is legal actively advertise marijuana and cannabis as being safe for use during pregnancy and helpful for nausea, but there is no safety data on that. We need to be careful to inform moms that THC is lipophilic and it accumulates in breast milk. So the dose that they are seeing personally, the baby may be even seeing a higher dose than that in their breast milk. There's conflicting findings on long-term impact, but there are neurodevelopmental concerns, and just the ability to parent when you're high can be particularly problematic. So you would want to have that conversation with the family. I would say this is not something that we would necessarily chase with additional drug screening if you don't have any other safety concerns. The one thing to know about all studies related to marijuana is most of the studies have prenatal exposure as well. There really isn't a study where a baby hasn't had prenatal exposure and then is exclusively exposed with breast milk. So just realize that those are always going to be confounding in those particular data set. So what about breastfeeding when mom is on medications for opioid use disorder? Baby is going to see a small percentage in the breast milk. It's not going to be enough to treat withdrawal symptoms. They should just continue to breastfeed as they normally would and then wean when they would have regularly decided to wean. So whenever it's appropriate for them, we encourage them to go for as long as they can. We don't want mom weaning her medication for her OUD in that immediate postpartum period. We want to respect her recovery journey as well and make sure that she's being allowed to continue in her recovery process without feeling pressure to wean just so she can breastfeed. Babies are often going to require higher calories, especially if they're having a lot of withdrawal symptoms. When you start seeing about a 3% weight loss per 24-hour period or greater than an 8% weight loss in total, think about increasing the calories in the breast milk or think about supplementing so that you can stabilize that weight before that baby goes home. It is critical for moms to stay engaged in the process. If they are breastfeeding, they need to be in a stable recovery follow-up plan as well. Post-hospital support can be really important. So check on her plan. Make sure that she's got some resources of how to continue this breastfeeding journey. Encourage her to attend support groups. It is just like any other mom who would be establishing breastfeeding. It can be quite difficult when they're learning. And mom's trying to recover from her delivery. She's in her recovery process and she's trying to breastfeed this newborn. And so there can be a lot of pressure on her during this period of time. So know and share the resources in your area. If you're unsure what resources may be in the mom's area, the Tennessee Breastfeeding Hotline is a good resource. So I encourage moms to use this, and they will find resources that are available to them. TennCare now covers lactation consultation. If mom is covered by TennCare, encourage her to look up what's covered under that TennCare plan or help her get some assistance there. And then the Infant Risk Center that I've talked about several times, that is a toxicology center based out of Texas, and they will look up medications that mom may be on, especially if you've got a mom on multiple psychotropic drugs that in combination can be problematic. It's important to call. We had a mom on a ketamine drip. You need to call and find out, how long does she need to wait after she comes off of that. Those drugs that we don't see commonly, they can look those up for you and help. Dilaudid is a perfect example of that. If you've got a mom on a Dilaudid drip, what's the totality, what's the dose that we need to not breastfeed on, and how long does she need to wait after it's off? Those are all questions that can be greatly answered by the Infant Risk Center. And then other breastfeeding considerations that I want to quickly mention is that HIV is no longer considered a contraindication to breastfeeding. So new HIV guidance was developed or published in November 2024 that allows breastfeeding with a negative viral load throughout the pregnancy. This needs to be done in conjunction with your infectious disease colleagues because the mom and the baby require repeat testing throughout their breastfeeding journey. So this would not be something where a mom would come into with a negative viral load and you would just say, okay, go ahead and breastfeed. You need to call the infectious disease provider and make a solid plan to make sure she has good follow-up in place. And then hepatitis B and C are not contraindications either. And so unless mom has cracked or bleeding nipples, and then at that point you would pump and dump that milk. But really that's out of an abundance of caution. Hepatitis B and C are not shown to cause transmission through breast milk. Prevalence of hepatitis C mirrors the opioid use disorder in Tennessee, and this won't be a surprise to anybody that it is highest in the eastern part of the state and works its way west. One thing to be aware of in your hepatitis C testing is if the hepatitis C antibody is positive, you need to reflexively do a PCR or RNA quant to check mom's viral load. If her hepatitis C antibody is positive, but she is not replicating virus, then she will not pass this to baby. And that's a really important distinction to make. If mom is hepatitis C positive and actively replicating virus and she has a viral load that's positive, then you want to make sure that there's a plan for testing baby. Babies need to be tested at around 2 months of age. They can have their own viral load tested. If you've missed that window and they're greater than 18 months of age, you would test the antibody and then reflexively test the viral load after that. If there's a question and mom comes in and she's tested positive for hepatitis C in this pregnancy but doesn't know when she was infected, but has older children, it's really important to go and look back for the older children and make sure they have antibody testing so you haven't missed a case of hepatitis C. The other thing to talk to mom about is in between her pregnancies, she can be treated for her Hep C. So it's a great opportunity to get her into infectious disease treatment in between her pregnancies. There are ongoing studies looking at treatment during the pregnancy itself, but we're not quite there yet. Discharge planning, this is an important key concept that we've worked on through TIPQC for quite some time now, and I hope that you all have a discharge checklist in place. If you don't, I would encourage you to go back and implement one for your hospital. But you want to make sure all opioid-exposed infants are referred to early intervention services, and we'll talk about that again in just a second. You want to make sure if the PCR on mom is positive that they have Hep C follow-up arranged with their PCP. If their PCP is not comfortable doing it, then make sure that they've got some ability to get back to a GI clinic in one of the tertiary centers. Developmental follow-up. So if they were diagnosed with NAS or NOWS, they really need to be seen in a developmental clinic, and that's going to be an important thing to arrange. And then referral to home visiting. If mom is amenable to having evidence-based home visiting come and help support the family, that is a really great spot to have additional supports in the home. Some of our moms may not be comfortable with that. It's really being thoughtful about if mom is not amenable to home visiting, just making sure she has good social support through her PCP, through the pediatrician. It is often helpful to call the pediatrician to give a warm handover when these babies are being discharged so that the PCP knows to look out for them and make sure that they attend their appointments on time. So when you're making the TEIS referral, remember that NAS and NOWS are an automatic eligibility for TEIS services. So sending in that diagnosis code is going to automatically make that baby eligible for services. Opioid exposure is incredibly important that these babies are also considered for services, but that requires a secondary MD review. So it's important that you use the correct P code for classification of what the baby was exposed to. You want to include the source of exposure, the approximate duration, and that can be really helpful for the secondary MD review so that these babies get appropriate services. The other thing that is great news in the state of Tennessee is we now have follow-up clinics in some of the green regions for infants with opioid exposure. And so these clinics provide medical services, medical home models, they provide developmental surveillance, they provide PEDS rehab services, PTOT, those kinds of things. So SHINE is located within Vanderbilt in Nashville. Baby Steps is within ETSU at Johnson City. And then Grow With Me is at Etch in Knoxville. And these three clinics can take referrals. So if you do have an infant who potentially could use a little bit more developmental surveillance or PEDS rehab services and you're having trouble getting services in your community, reach out to one of these clinics and see what they may be able to provide your patient. So very briefly, early relational health. This is a fairly new concept that I highly encourage you to look at more when you have time. The AAP, American Academy of Pediatrics, has a wonderful website that if you just type in early relational health or infant mental health, it will pull it up for you. Basically, the definition is a framework that explores the role of early relationships and experiences in a healthy development across a child's lifetime, pointing out how important that birth to 3 and that sort of nurturing that needs to happen in that time period, how important that is for brain development and for this infant to be successful. Relationships in those early years are just foundational as our children are going to be growing, and we can do so much as providers to kind of help nourish that. The AAP has a wonderful list that breaks it down by age of just talking points that you can use with the family so that they understand, oh, that little 2-month-old is going to be mimicking your face. And so really looking at them and making those faces and responding to their cues can be really important. And then I love the concept of what does this relationship look like and what does this child need? Well, safe, stable, nurturing. Those are the 3 key things that children need. They don't need a whole lot of extra gadgets and toys, etc. They need to be safe. They need to feel like their caregiver is going to meet their needs, and they need to know that there are expectations and that person is going to be there for them. And those are the things that you can help encourage, especially in this population where they may not have the same caregiver from person to person. It's going to be important that you help to kind of shore up what is, when they do have those custodial changes, where is that stable person? Where is that safe person for them? And when you are rounding, so most of you will be taking care of newborns in the hospital in some form or fashion, recognizing and calling out specifically what's going well for that family. So you may have a family who comes in and they're not in recovery at all. They can do skin to skin, they can change diapers, they can take care of their baby, they can follow non-pharmacologic measures. The more you call those things out and tell them, you're doing a great job with that. This is going really well. I'm so proud of you for doing this. Filling out something as simple as filling out the application to go to a recovery center. I mean, call it out. Make a, hey, that's wonderful. Look, what a great job. That's a wonderful first step for you and your baby to be able to discharge safely. So all of those things can go into that relationship building. And then making childhood a positive experience. So instead of talking about ACEs, we really want to think about what are our positive childhood experiences and when do those start? Those start immediately. So those start with mom singing a lullaby at birth. Those start with dad reading a book as soon as they get home. Those start immediately. And so the more you can kind of help the family realize those positive things that they can do with their child, then you can help them establish those positive childhood experiences. We are very lucky. We have AIM High Tennessee that is specifically focused on infant mental health. They offer trainings around infant mental health in the state of Tennessee. They also offer the infant and early childhood mental health warm line service. And this service is that 1-866 number that you see there that can give advice about perinatal mental health concerns, attachment bonding concerns, birth trauma support, can really let you know about those mental health services that can be really important when babies are first here. I would encourage you to go to their website and learn more, especially the AIM High Tennessee and then the American Academy of Pediatrics have wonderful resources along the infant mental health. So this is the end of our discussion today. I hope you have some nuggets of information that you can take back to your home institution. Feel free to reach out to TIPQC if you have additional questions or topics you would like for us to cover.